to do them for you. And then a big thank you to all of you for coming to listen. So I'm hoping that you're finding these webinars helpful. Very warm welcome to those who have been before, and equally warm welcome if you're joining us for the first time. So my name is Pat Langley. I'm a dentist, no longer wet gloved. So me personally, I don't get involved in infection control procedures anymore. What I do get very, very involved in, though, is helping practices comply with all the myriad of regulatory requirements that we now have to comply with. And today we're going to cover infection control, and we're going to, I've called it an update and mythbusters. So I'm going to do it in the form of some commonly held myths and just ask the question, is this true or false? Because I think sometimes myths get embedded and then become, this is how we do things. So I think it's always good just to revisit what is required. And of course, I am very aware that infection control is one of GDC's recommended subjects. So this will count towards your GDC learning outcomes. So infection control update and mythbusters, and what we're going to cover today is quite a long list. And so, and this is essentially, these are the questions that we often get asked about at Dentistry Compliance. So Dentistry Compliance is the company that I founded in 2010 as Appeline to provide help and guidance in all matters relating to regulatory compliance, of which infection control is, of course, a very big one. And we quite often at Dentistry Compliance get asked questions on this very long list of things here. So we're going to cover all of these items, and then leave plenty of time at the end for questions, which I'll be very, very happy to take. And then any questions that you have after this, because I'm aware that a lot of people are watching live. Also, a lot of people will watch this on demand. So the very last slide is how you get in touch with us if you do still have any questions. So that's what we're going to go through. I won't read it all out. I will just get started. So the first of these, the first true or false is that we can completely, for some reason, we can completely revert to pre-pandemic infection prevention and control measures. So is that true or false? Well, I'm going to suggest that actually it is false, and then I'm going to explain why. Before I do that, let's look at what has changed as a result of the pandemic. Well, actually, Rose and I were discussing just now that pretty much everything has changed as a result of the pandemic, and not least infection control and how we go about that. So let's just have a little look at that before we get going. So at the start of the pandemic, it was very much, we knew nothing, and it was very much a case of the blind leading the blind. And, you know, as we all know, the practices were shut down, and then SOPs were created so that practices could reopen in a very different way, though. And I think now, as a result of the pandemic, that we've become much better at understanding, assessing, managing both clinical risks and also infection control risks. And my plea really is that we don't forget the lessons that we've learned. These are really important lessons. Now, why was it the blind leading the blind, and why did we know nothing? Well, because before COVID, we focused on primarily measures designed to protect against bloodborne viruses, and these we called universal precautions. And we were required to think that and believe and practice as if everyone could be infectious. And so we focused almost entirely on bloodborne viruses. So things like hepatitis B, like HIV, and like hepatitis C. And then, of course, the pandemic came along, and that was all about respiratory viruses, which we really had not as a profession, and using our guidance, which I'll come on and talk about more in a minute, we really hadn't given a lot of thought to respiratory viruses. And for the first time, we were forced to think about respiratory viruses. Now, all respiratory viruses are transmitted through droplet and aerosol contamination, through being close to an infected person. And when I say close, I mean within 2 meters, and also touching recently contaminated surfaces and then touching our face or nose. And that's how all respiratory viruses are transmitted. And then during the pandemic, we developed what was called transmission-based procedures. And the idea of this was that it was to reduce the spread of this unknown and, quite frankly, very dangerous virus. And what I'd like to consider now is how we can use our learnings to protect us from all respiratory viruses. So yes, COVID is still around. COVID still causes, very nasty infections or very mild infections. The virus has mutated over the years. This year, we've had a massive flu epidemic, I'm going to call it really, and we can use these learnings for all respiratory viruses. So where are we now? Well, with respect to COVID, then all official guidance has been withdrawn, and the emphasis now for actually all respiratory viruses, not just COVID, but for flu, respiratory syncytial virus, RSV, the emphasis now is on using clinical judgment and local risk assessment. So if, for example, you are in an area where flu is really spreading fast, then you're going to be at higher risk of catching flu than somebody in an area where it is not spreading like wildfire. And that means then that there may be some times and some circumstances that you want to revert to some of the things that we did during the pandemic, these transmission-based procedures. So what should we do now? Well, the plain fact of the matter is that team members with a respiratory infection shouldn't work. And I put shouldn't, not mustn't. During the pandemic, it was very much mustn't. But think about it. So somebody comes to work with a horrific cold, they cough and splutter all over everybody, irrespective of trying not to, and then suddenly half a dozen team members go down with whatever it is they're infected with, and it can cause havoc. Now, I put shouldn't rather than mustn't because this is very difficult in practice. If you want to access the guidance, then it is still current. It's there on the slide now. That is still current guidance, and it's not just about COVID. It's about managing with symptoms of all respiratory viruses. But the fact of the matter is that in an ideal world, team members with a respiratory infection shouldn't work. What if you're coming up to year end of UDAs and really you feel that you've got no choice? So, whilst this is an ideal thing, I do understand and appreciate it can be very, very difficult to actually implement it. That's the guidance though, and it's up to individual practices to make local risk assessments and also use clinical judgment on what the best thing to do is. What else do we need to worry about? Well, we've talked a little bit about bloodborne viruses. I read in the paper today that norovirus is having a massive surge at the moment. Obviously, we're just starting to come to the end of the worst seasonal flu season for 10 years. And then we've got other respiratory illnesses which cause havoc as well. So things like respiratory syncytial virus. We need to be concerned about herpes simplex, which I'm going to talk about in just a minute. And then there will be other diseases that come along and emerge that we weren't expecting, just like COVID did. And then obviously we've got this risk that one day the SARS-CoV-2 virus, the virus that caused COVID, could mutate and become something nasty again. I mean, it's not showing any signs of that, but you just really don't know. So we need to be prepared for bloodborne viruses and respiratory viruses. Speaking of cold sores, this is another myth question I want to pose. It's okay to treat a patient with cold sores, provided we're careful. Is that true or is that false? Well, in my view, my clinical opinion, that it is not advisable to treat a patient with cold sores. And the reason is that the herpes simplex virus is extremely infectious. So it poses a risk to the treating clinicians, the supporting team members. It also causes pain and discomfort to the patient. So it is best, if you can, to avoid treating patients unless it's really urgent. So you've got a picture here of a patient with a cold sore, which has started to crust over. So it's starting to come to the end of its particularly infectious phase. Again, if it's possible, ideally, all non-urgent appointments should be delayed until the lesion has healed. And it's not just a case of the patient catching cold sores, the team treating the patient catching the herpes simplex virus and just having lesions around the lip. There are some well-documented cases where dental nurses in particular have gone blind as a result of infection with the herpes simplex virus. So absolutely ideally, I would suggest to you that you delay all non-urgent treatment. And if urgent treatment is required, then there are a few things that can help reduce the chances that the virus will be passed on to the clinical team. So avoid using anything that generates an aerosol. So that would be the air rotor. That would be irrigation with water using the slow handpiece or ultrasonic scaler. So avoid doing that. Find something else to do that will help the patient. Make sure you wear PPE that covers all exposed skin, and eye protection is absolutely vital. As I said, there are some well-documented cases of dental nurses in particular who have gone blind as a result of infection with the herpes simplex virus. Next myth next question, true or false question, CQC inspects against HTMO 105. So HTMO 105 was published in 2010, updated in 2013, and not since. I have heard anecdotally that it is being updated, but I have no more details on it than that. And it basically lays out the procedures we use for decontamination in primary dental care. And I think a lot of practices think that that's what the CQC is coming to inspect against. And so this is in fact false. And what the CQC does inspect against is a thing called the Health and Social Care Act Code of Practice for the Prevention and Control of Infection. Nice long wordy title. And what they do is they use HTMO 105 as a guide to whether or not you comply with this code. So it's kind of a little bit semantics here, because at the end of the day, you have to do everything that's in HTMO 105, and that just happens to be the guidance that shows whether or not you are complying with the Health and Social Care Act Code of Practice. So a little bit about HTMO 105 now. So that HTMO 105 lays out essential quality requirements for all dental practices, otherwise known as EQR, and it also lays out best practice. And there are three fundamental differences between EQR, which all practices have to comply with, and best practice. So best practice says that you should be using a washer disinfector for pre-autoclave cleaning. It says that best practice says you should have a separate decontamination room. So decontamination should not be done in the surgery. Under EQR, it is permitted, maybe not advisable, but it is permitted. And you should store instruments away from the surgery. So that would be in a designated area or the clean side of the decontamination room, but not in the surgery where you are generating aerosols. And so that is what best practice says. Now, it also says, the updated version 2013 says that all practices should have a written plan for achieving best practice. Originally, they were going to require practices to achieve best practice, which practices in Scotland are required to do and practices in Northern Ireland. In England and Wales, the regulators pulled back from requiring everyone to have best practice in place, but they have said that you should have a written plan for achieving best practice. Now, if you are a new practice or setting up a new practice, or you are undertaking significant refurbishment in your practice, then you should, not must, you should implement best practice. So I hope that clears up some of the myths around that. Infection control policies and audits are a pointless tick box exercise, and CQC inspectors are the only people interested in them. Is that true or false? Well, it may be true, but it shouldn't be true. So really, there is no point in having infection control policies and undergoing and performing audits that are not real living items. So it's pointless having an infection control policy that lays out generic guidance on things that don't apply in your practice. So for example, an infection control policy that says that we have a separate decontamination room when you haven't is pointless. So that is a pointless exercise. So make sure that your infection control policy reflects what happens in your practice. So it should, if you like, be an operating manual to how you undergo your infection control procedures. Infection control audits are a pointless tick box exercise. Well, only if you just go through as a pointless tick box and just tick all the items and say that you comply with everything. That is a waste of time. If you do it on paper, it's a waste of paper and it's potentially a waste of money. So make your infection control audits count. You need to undertake an infection control audit every 6 months and make sure that it's an accurate reflection of what actually happens in your practice. And so let's think for a moment about what infection control includes. Well, it includes all measures for and procedures for preventing and controlling the spread of infectious microorganisms. So that means your written policies and protocols, that means how you train your team, and it means your auditing. So with an infection control audit, yes, you need to undertake it every 6 months. And then, as I've just said, please don't just make it a pointless tick box exercise. I have seen that happen in practices where you just go down and tick everything as yes. The idea is to find out if anything needs to change, and you need to put some rectify a few things that are not happening. Discuss the outcome at a practice meeting. Decide if anything needs to change. Make the changes. Make sure the whole team know what you've done and the results of the audit, and then just record what you've done. And do remember that if it's not recorded, it didn't happen. Obviously, this isn't completely true, because if it did happen and you didn't record it, then it isn't true. But I think get into the habit of recording what you've done, not as a pointless exercise, but so that you have a trail of how you have created continuous improvement in your practice. Next myth. So hand hygiene is not as important now as it was during the pandemic. So during the pandemic, we were all encouraged to wash our hands for 20 seconds whilst singing happy birthday twice. So is it true or not that this is not as important as it was? Well, this is absolutely not true. because hand hygiene is one of the most important ways that we can reduce transmission of all healthcare associated infections. So I think it's very well known that in hospitals, staph aureus is transmitted very easily because the hand washing regimes are not what they should be. So hand hygiene has always been important. It's not any less important now that we're not living with the pandemic. So what is hand washing good practice? So wash hands on arrival at the practice and regularly throughout the day. Use hand sanitizer as an adjunct to washing with soap and water, but not as a replacement for. One of my pet hates is electric hand dryers. Now this is not mandatory at all that you don't use them. Just think about what you're doing though with a hand dryer, electric hand dryer. So you are essentially spraying, potentially spraying infectious microorganisms around when you use the electric hand dryer. So do consider using paper hand towels instead of electric hand dryers. Very good practice to wall mount your hand wash solution, your hand sanitizer and hand cream. So do this in the clinical areas and the toilets. Now the benefit of wall mounting these things is that it takes it off the surgery work surface and reduces clutter. So having these things wall mounted is good practice. Not required, it's just good practice. I think you see evidence everywhere you go that people do still want to be using hand sanitizer. This is not a requirement at all. It's something that you would make a decision on yourself in the practice as to whether you want to do that. Consider if you're going to have hand sanitizer, then perhaps at the entrance and the exit to the practice, have it in all toilets, and then perhaps in other appropriate places like the reception desk. So you do still see this in a lot of places. As I say, it's not just dental practices, generally shops and so on. It's not a requirement, it's just something you can make your own decision on as to whether you want to do that. A little bit now about clinical hand washing basins. So hand washing basins should only be used for hand washing. So that applies whether it's in your decontamination room or whether it is in the surgery. So you have to have a dedicated hand washing sink only. And then there are requirements based around that, which is that a hand washing sink should have mixer taps, as you see, like you see in the picture there. It should have no overflow and it should have no plug. Now, if your hand washing sink doesn't comply with no overflow and no plug, then you can get a little device that you just pop over the overflow from any hardware store. So rather than replacing the sink altogether, you can make amendments to it. So pop a little cover over the overflow, and then if it does have a plug on it, then cut it off or remove it if it's a pop up and down plug. So it is important though that it doesn't have an overflow, it doesn't have a plug, and it must have mixer taps that are elbow or wrist operated or sensor operated. That's another alternative as well. We've already talked about wall-mounted liquid soap and paper towel dispensers, and then do consider displaying hand washing instructions over, I would say actually every sink. Certainly the hand washing sinks, but I think it's very good to have this also in the toilets as well, so that it just shows how you should be hand washing. You can get hold of these posters free, and then if it's not laminated, then get it laminated and then pop it over all hand washing sinks, both in the toilets and in the decontamination room and in all surgeries. Just reminds everybody what they should be doing. So what does HTMO 105 say about hand hygiene? Well, it says you should perform hand hygiene, that is washing your hands with soap and water before and after each treatment session, before and after removal of either donning or removal of PPE, following the washing of dental instruments, before contact with instruments that have been sterilized, and that's whether or not they're wrapped, after cleaning or maintaining decon devices used on dental instruments, and after decon work. So that's what it says in HTM 0105. Also, wash your hands. This is not from HTM 0105. Also, you should wash your hands after contamination with blood or saliva, which obviously your hands shouldn't be contaminated with blood or saliva because you'll be wearing gloves. In case they are for any reason, so perhaps your gloves have been torn or you don't happen to be wearing gloves at the time you encounter some blood or saliva, then wash your hands straight away. After cleaning up any spillages, after contact with contaminated dental equipment, after handling waste, and at the end of a clinical session. I think also going back to what we said at the beginning about maintaining lessons we learned during the pandemic, and this is nothing to do with the practice now, but, consider also washing your hands when you come in from being out, from going to the supermarket or being wherever, because as we said earlier, good hand washing is of paramount importance in reducing transmission of all healthcare acquired infections. So disinfect hands after removing gloves and provided your hands are not visibly soiled, so you can actually just use decontamination. You can actually just use hand sanitizer in between patients if your hands are not visibly soiled. If they are visibly soiled, then you should wash your hands instead of disinfecting them, and never use hand sanitizer on the surface of gloves because it will cause the gloves to deteriorate and tear. So don't do that, and there should be no reason why you ever need to do that anyway. Hand cream, particularly important at this time of the year in cold weather, but actually because you're going to be washing and drying your hands so regularly and also sanitizing them, then skin can get very dry. And if it does and it cracks, then that then leaves you prone to infection. So do use hand emollients. Again, do make it wall mounted if you can. Should be perfume free, colorless, and very important to use it though, so that your hands don't dry out. Right, popular subject. We've been asked loads and loads about this. What can you and can't you do with nails and nail varnish? Well, there was some guidance published not that long ago saying that artificial nails are not as bad as one might think, and under the right circumstances are okay. It's okay to have nails with gel nail varnish on. Now, my personal view on this is that this is not a good thing to do. Never mind the infection risk. I don't think it looks professional. We are in a clinical environment, and I don't think it looks professional to have nail varnish on. Certainly not anything like the nail art in the picture. And gel and acrylic nail varnishes last for weeks and weeks and weeks, and in my experience can cause fungal nail infections. So I think that it's not a good idea, no matter what the guidance says, to have either artificial nails or be allowed to wear nail varnish. This is for the clinical team, for the people, receptionists, practice managers, and so that's a different matter. And then it is really just what does or doesn't look professional. No rings apart from a plain wedding band, because microorganisms will lodge under the rings, and no wrist jewelry, and make sure that you cover cuts and abrasions with waterproof adhesive dressings. So I'd be pretty sure we'll get some questions on that at the end, which I'll be very happy to answer. A little bit about gloves now. They should be non-latex, so nitrile. They should be well-fitting. You should have good tactile sensation in your hands when wearing the gloves. They should be non-powdered, low protein, low in residual chemicals, and you should keep them in a clean, dry area. Preferably that is not, so that the gloves are not exposed to any contaminants that are in the air after you've been doing using aerosol procedures. So either in a box in the cupboard or wall mounted with a sort of protective cover, means that they don't get contaminated while you're using them in the surgery. So that's a little bit about gloves. Now we're going to move on now and talk about immunisations for a moment. So the next true or false is immunisations are not all mandatory. True or false? Well, actually that is true. One of the few that is true. And where we go for guidance on this is the Green Book, chapter 12. That is chapter and verse on what we need to do in the dental practice. And there is only one immunisation that is mandatory, and that is hepatitis B. Everything else is a should, and things that should be up to date. Now, the GDC also has a view on this, and it says that you should have hepatitis B, and you should have also up-to-date immunisations against, but it doesn't specify against what, it just says immunisations should be up to date. And I think we all know that there's been a falling off in enthusiasm for vaccinations in recent years, and that's led to a massive increase in measles. So I think really thinking very carefully about all of these things and making sure that they are all in place. As I said, it's not mandatory. It's a very strong should, and it's a good idea and good practice to be have all those immunisations in place. Perhaps also consider seasonal flu, respiratory syncytial virus. That's only offered to people over a certain age, over, I think it might be 75 actually, and consider COVID-19. So, but as I say, the only thing that is mandatory is hepatitis B. A little bit now about PPE. So the PPE that we wear in clinical situations are gloves, which we've talked about, masks, eye protection, surgery clothing, disposable aprons, and footwear. So we're going to look at those things now. So masks, there was huge amount of debate about the efficacy or otherwise of masks during the pandemic, and then various studies came out to show that actually masks probably do provide more protection than we've given them credit for in the past. So in the past, I think we thought they were only a barrier against splatter and foreign bodies, but they have now been shown in a number of well-respected surveys that they do protect against microbes. Only though if they are used correctly. They must be single use. If you reuse a mask, then breathing into it for a prolonged period of time, the mask becomes damp, and that's not going to protect you at all. In fact, if anything, it will attract microbes onto your face, which is not ideal at all. And they must only be worn in the surgery as well. And not only that, they must be worn correctly. They must not be left dangling under your neck, and they must cover your mouth and nose. I've seen many instances of masks that only cover the mouth and then the nose is left uncovered. They must be worn correctly. They must cover the mouth and nose, and they must not be allowed to dangle under the chin and then so that you walk around the practice with the mask under your chin. See that on lots of clinical photographs as well. So don't do as Barbie did, do the right thing. There might be some situations in which you want to revert back to FFP3 or FFP2 respiratory masks. If you decide you want to do that, for whatever your own reasons are, and there are still people who do want to do this, they must be fit tested. You must keep the certificate, and this is a legal requirement for using FFP2 and FFP3 masks. So they must be fit tested before you use them, and then immediately before you use them in the practice, then they must be fit checked just to make sure that they are fitting correctly, because if they're not, then there's no point in wearing them. And certainly, out and about, certainly in London, I have seen a number of people choosing to wear FFP2 or FFP3 on the underground. And, I think particularly in view of what we talked about earlier, which is that it's been a terrible flu season, it's not a terrible idea to do that. But this is entirely up to you, your own clinical judgment, your own clinical risk assessments, and make your own decision. If you do decide you want to do it, then it must be fit tested and it must be fit checked. If you're going to wear it in the surgery anyway. FFP2 and 3, the wearer must obviously be clean shaven, and if not, then a powered air purifying respirator hood is a very good option to consider, and much easier and more comfortable to wear. And certainly I know a lot of people did use these during the pandemic. I must stress again, though, that all of this stuff is optional now, and it's up to you to decide upon. Eye protection. Eye protection is imperative for clinical team members. So that's for the dentist, the hygienist, the therapist, the dental nurse. Anyone treating a patient must wear eye protection. And it is also imperative for patients that they always wear eye protection. That eye protection will protect against flying bits of amalgam, bits of tooth, bits of orthodontic wire, bits of dentures. It will protect against foreign bodies and injury. Obviously, it'll also protect against splatter and aerosols. It does also discourage you from touching your face with contaminated gloves. And as I said, it is mandatory for patients to wear eye protection at all times, including for examinations, including for if they're sitting up and having a dentures. So make sure that you get into the habit of always putting eye protection on your patients at all times. Surgery clothing. It's okay to pop out at lunchtime and travel in your surgery clothing. So I'm kind of hoping this isn't a dentist here and it's a naughty doctor instead. Is that true or false? Well, it is completely false, and it is not okay to pop out at lunchtime and travel in your surgery clothing. And I think, again, just harping back to the pandemic again, I think this is something that we have learned, actually, that to be wary of infection that is transmitted on contaminated clothing. So it is not okay to pop out or do anything other than be in the surgery in your surgery clothing. So surgery apparel should be, as it says on the tin, surgery only. So only wear it in the practice. It should be clean on every day. Now, again, this is up to you to think about how you're going to implement this. But I do know of many practices, my own included, where the dentists actually still have a regime that is similar to what they used in the pandemic. So they put, they launder their surgery outfits at home. They have a clean outfit every day. They take the used surgery items home in a pillowcase, and then they wash the surgery clothing with the pillowcase. So that's quite a good, it remains quite a good learning from the pandemic. If your scrubs are visibly soiled, then they should be changed as well. So yes, clean on every day. If your clothing becomes soiled though during a day, then that should be changed as well. If you think that splatter is a huge danger in the practice, then so you're doing aerosol generating procedures, then do wear disposable aprons, and for decontamination processes as well. It's a really good thing to do. When you wash your surgery clothing, do it at the highest suitable temperature for the fabric, and it will say on the item what temperature it should be washed at. It should be washed separately from all other items, household items as well. Now, obviously, some practices have a washing machine in the practice, and so it is done in the practice. If you do that, then make sure the washing machine has been installed in line with local water authority guidance. You need to have a thing called a type A air gap, and you should be very sure that it complies with the local water authority regulations. If it doesn't, I do know of cases where the water boards have come to inspect. So there's two choices there: either launder it at home or in the surgery. If you launder it at home, then make sure in the surgery, then make sure it complies with local water authority requirements. You don't have the same requirements if you launder it at home. You can just launder it in your normal washing machine, but do launder it separately. Footwear. Okay, so footwear must be visibly clean and well maintained. Now, most people do change out of their normal shoes and into some form of surgery footwear, and clogs are popular and a very good choice, actually. They are non-slip and they will protect the foot from contamination and sharps injuries. What is completely unacceptable is open-toed sandals in the surgery. You are leaving yourself wide open to contamination and perhaps even worse than injury from dropping an instrument. And if it's a sharp instrument, then even more of a risk. So make sure that you have very suitable surgery footwear. We're going to talk a little bit now about the myths involved in cleaning and sterilization of instruments. And you can see there we've got the different methods of cleaning and sterilizing instruments. So we've got a washer disinfector, top left, we've got an ultrasonic. To the right of that, we've got manual cleaning, and then we've got an autoclave. So let's have a little think about this. So next myth, true or false, pre-sterilization cleaning is as important as autoclaving. Is that true or false? It is, in fact, true. So instruments must be clean, must be visibly clean, so that you have the best possible chance of sterilization being successful. Now, this matrix band, which actually is quite a famous photograph, and it's from some work they did in Scotland, where this is the matrix band post sterilization, and it's the reason that matrix bands are now single use only. So it is impossible to clean that matrix band. So look at all the folds in the matrix band, look at the blood congealed on the matrix band. It is impossible to clean that. And that matrix band will come out still not sterilized at the end of an autoclave cycle. So matrix bands are now considered to be disposable items because you cannot reliably sterilize soiled instruments. And actually, when you look at it close up like that, you can really see why that you wouldn't be able to sterilize that. So there are three methods of pre-sterilization cleaning. You can use a washer disinfector, you can use an ultrasonic instrument cleaner, and you can use manual cleaning. Now, it's a bit of a mystery to me why the BDA, because before HTMO 105, everybody used the BDA guidance for how we should decontaminate our instruments. And the BDA for years and years and years and years have said that manual cleaning is to be avoided. They didn't, obviously they're not a regulatory body, so they couldn't say that you can't use manual cleaning. And then HTMO 105 comes along, and actually it talks about the fact you can use manual cleaning. You must also have a means of inspecting the instruments that after you have cleaned them, either using a washer disinfector or a ultrasonic or with manual cleaning. And that's to check for organic matter, so anything still stuck on the instruments, for blood and for staining, and you should then re-clean if that is present. So manual cleaning, as I've just mentioned, is acceptable under essential quality requirements in HTM 0105. But, big but here, it is not the preferred method for 3 reasons. One is it's not reproducible. That means that you can't be sure it's been done in the same way to the same level of efficiency every time. It's very difficult to validate it because of that reason. And there's also an increased risk of sharps injuries. So yes, you need to be able to manually clean, and that's what you need the sinks in the decontamination room for. Ideally, though, it should only be used as a backup. And ideally, you should either use a washer disinfector or you should use an ultrasonic. If you use an ultrasonic, then the instruments go into the ultrasonic and they should have a cycle that is undisturbed for 10 minutes. So don't ever add more instruments to an ultrasonic partway through the cycle. If you are going to use manual cleaning, and as I've said, it is acceptable under essential quality requirements, then it is advisable to soak the instruments in an enzymatic solution prior to cleaning them. Make sure you use the correct detergent dose and do laminate and display your written protocol for manual cleaning. Obviously, you should wear heavy-duty gloves and make sure that you are cleaning the instruments away from you. And that you sterilize the brush that you have used, or using it disposably, I don't think is environmentally sound, so or sensible. So make sure that you do autoclave the brush and do replace it regularly, not disposably, but regularly. You should monitor the water temperature, and for that you should use a digital or a mercury 3 thermometer. You need to make sure that the water temperature during manual cleaning process remains below 45 degrees centigrade. If you try and clean instruments above 45 degrees C, then that can lead to protein residues actually sticking to the instruments, meaning that they're not clean, and therefore you won't be able to autoclave them and sterilize them successfully. And it is more difficult to remove. So monitor the water temperature, do record the results. Now, it is something the CQC does often ask about, but I think that more important than what the CQC is going to ask is the fact that, as I've just said, if you clean the instruments at the wrong temperature, then it is likely to be ineffective and therefore a waste of time. So do record the results, and just going back to, if it's not recorded, it didn't happen. Next myth, good ventilation. We're going to talk about ventilation now a little bit. Good ventilation doesn't matter so much now the pandemic is over. Now, this is a really big one, isn't it? Because prior to the pandemic, nobody thought about ventilation at all. Unless perhaps you had a brand new practice built and the building regulations inspector came around and said you must have 10 air changes per hour, which has been a building regulation for in excess of 20 years. Mostly people didn't do this, and sometimes building inspectors said you do need to do it, but mostly nobody came to check. Then suddenly, ventilation is hugely important because we've got a respiratory virus, a dangerous respiratory virus. So Good ventilation doesn't matter so much now the pandemic is over, true or false? Absolutely, definitely false. It always mattered, we just didn't take any notice of it before. It still matters, and it will always matter that we have good ventilation. So we'll go back to why and how respiratory viruses are spread. So breathing, coughing, sneezing, speaking, shouting, all of these things create an aerosol and will transmit viruses, respiratory viruses. And actually, breathing is the least, it causes the least amount of release of infectious respiratory viruses. Things like coughing, sneezing, speaking, and shouting cause a lot more the virus to be released. So, and obviously we sit and talk to our patients and we interact with them. Hopefully we don't shout at them, but we certainly speak to them and they speak to us. And also, you can't control whether they're going to sneeze and cough or not. So protecting against respiratory viruses by having good ventilation is really important. So let's think about windows then, because windows are great ventilation, right? Well, they are ventilation, yes. Whether or not it's great is debatable. Certainly in the home, windows are what we use for ventilation. In the practice, we do just need to think a bit more carefully about it. So natural ventilation using a window is uncontrolled. And if all you're relying on is having an open window, you can only assume that you've got 1 air change per hour happening from the open window. Current building regulations require 10 air changes per hour. So that means that an open window isn't on its own, isn't enough. The good news actually about windows, sort of good news, maybe not such good news actually, because if you don't open the window very wide, then the ventilation is reduced. But the good news is that when it is cold outside, then you don't have to open the window as wide, because the bigger the difference between the temperature outside the surgery and inside the surgery is it gives you better ventilation. So if the difference is bigger, you've got better ventilation. If the difference is similar, so say in the summer and you've opened the window and it's pretty much the same temperature outside as it is inside the surgery, then the ventilation is not as good. So that does mean that you don't have to open the windows as widely in the winter. So I think from this we can deduce that just relying on a window isn't really enough. And so you do need some form of mechanical ventilation in addition. So there are plenty of different types of mechanical ventilation. Some of them are very onerous and noisy, and some of them, things like expellers and that sort of thing, are much less so. But again, it's up to you to make a decision locally about what the best thing is for your practice. Now, it may even be that it'd be a good idea to call in a ventilation engineer and just have a little think about, can we make any changes here? The big problem, of course, arises in practices that are in buildings that are listed buildings and they can't make any adjustments. And so in that situation, aerosol generations should not be performed in a room that has no natural or mechanical ventilation. Now, again, it's one of these things that's a bit easier said than done here. What do you do if you are in a listed building and you don't have any windows and you can't install mechanical ventilation? Well, that's where air filtration devices can be quite useful. During the pandemic, the SAGE group, the Scientific Advisory Committee, did say that actually air filtration could have a place. If you're going to use air filtration, then obviously you need to make sure that it is serviced regularly and you have records of it being serviced so that you know that it's working properly. Also, be very aware, actually, as you are with all things, of things that are just marketing spiel. So just make sure that if you're going to have an air filtration device, that you have checked that actually the marketing spiel, the marketing claims are actually substantiated. So be careful before, they're expensive pieces of kit, so you want to make sure that they are actually doing the job that you've bought them for. But they can be a very useful thing to use in a room, in a surgery, in a listed building where you can't make any adjustments and you don't have a window. So just something really to think about there. Next myth, environmental cleaning. This can be done by anyone and no special training is needed. Is that true or false? That is false, as I'm sure you all know. So environmental cleaning must be done by people who've got appropriate documented training. Now, obviously quite a lot of practices choose to have somebody, or somebody in the practice chooses to do the cleaning for the practice rather than having a contract cleaner. So that the people in the practice that do it must also have documented appropriate training. The training can be done in-house, that's not a problem. It must be documented though. And if you employ an agency, a cleaning agency, make sure you ask to see the training records for everyone who will come out and perform environmental cleaning in your practice. You need to have environmental cleaning schedules, and these schedules should specify how frequently different items are cleaned. So, for example, you've got high touch areas that are frequently touched. This is things like door handles or light handles, the operating light handles, and your cleaning schedule should specify how frequently these items are cleaned. Door handles is an interesting one, going back right to the beginning where we talked about how respiratory viruses are transmitted. So imagine a patient who's got a cold, or even worse, they sneeze on the way out of the surgery, they use the door handle to get out of the surgery, and that item, the door handle, is then contaminated. So really frequent cleaning of surfaces like door handles is really important. So this applies equally to cleaning contractors and team members. So you should check the cleaning schedule regularly, and also so that is that the schedule will tell you what they're saying has been done. So either this is team members in the practice, or this is an external agency. So the cleaning schedule will say what has been done. What you want to know, though, is what is the quality of that cleaning. And so if you come across cleaning that is of poor quality, then it's important that that is rectified. We've already talked about this a little bit. So we talked about door handles and the operating light switch, but also light switches on the wall are frequently touched surfaces, as are telephones and keyboards, and you should have records of all the cleaning done in your practice. Mops and buckets. So we're coming to the end now, and then I'm going to give you lots of opportunity to ask questions. So mops and buckets, these seem to cause vast amounts of confusion. They must be correctly color-coded and correctly stored. Now, you have to store the mops with the mop head up, which seems to me utterly bizarre, because then if the mops are contaminated, then the contaminated water just runs down the mop handle. Nevertheless, that is what the NPSA guidance, National Patient Safety Agency, says that is how you should store mop heads. Make sure you use the right color mops and buckets in the different areas. So red is for your washrooms and toilets, blue is for offices, green is for kitchens, and yellow is for clinical and decontamination areas. So they're trying quite hard there, aren't they, I think? And there's another picture that these are pictures that we've taken from practices that we have visited over the years, and they're trying quite hard here. I think their mops have not got the heads up there, so just need a little bit more work there, but they are at least trying. And then I'm going to, for anyone who thinks that all this is over the top and we shouldn't be worrying so much about it, I'm just going to show you some pictures of, obviously not Barbie, never seen Barbie, but these are pictures of some decontamination and infection control horrors that my team at Dentistry Compliance have seen over the years when going into practice. So the one on the top left there, that's the area they clean their instruments. And, we're not going back 20, 30, even 10 years. We're going back maybe 10 years, but we're certainly not going back any more than 10 years. And these are pictures that were taken in the last, certainly in the last 10 years, and some of them more frequently and more recently than that. So we've got that totally horrific sink at the top left there. We've then got the ultrasonic soup, as I call it, and this is an ultrasonic cleaner that they last used on a Thursday and left like that, and our practice advisor visited the practice on a Monday, and that the ultrasonic soup had been left like that, so that's pretty horrific. And then we've got the box there. It is yellow. The box there of single-use items. That's definitely not how you should be handling it. Single-use items, of course, are a very interesting thing, aren't they? Because HTM 0701 tells us that we should be reducing the use of single-use plastic items wherever possible. And it is possible, I think, to give that some thought. Then we've got that box there with files and reamers in it. Again, a recent-ish photograph. We've got top right there. We've got everything stored in an area that really is extremely cramped and very prone to potential disasters. Bags overstuffed could easily break open. My all-time favorite, though, is the Henry Hoover that is linked up to be the suction motor. Now, this is quite a famous slide and picture. This is a practice I actually visited myself, so I do know that this is not AI. It's not a fake picture. I actually saw this with my own eyes, maybe about 8 years ago, something like that. So all of these things are out there, and of course, you wouldn't be on this webinar if you were doing things like this yourselves. So I think that, but just to know that that there are horrors still out there, I think is just pretty horrible. And of course, the biggest problem with all of this is that you don't know what you don't know. And this is why we have a lot of questions all the time about infection control. And we're always happy to help with these questions. And there's a lot to balance. So in terms of infection control, it's important that you have an infection control policy with a named infection control lead. There's no question that the right technology and digital solutions can help because there is so much to balance. So how can technology help? Well, there's a lot of help out there. There's compliance management software that we have at Dentistry Compliance. Our competitors have as well. And then you can look at how compliance procedures and processes can be automated. So things like automated audits, things like digital checklists, and all of these things, digital surgery checklists, all of these things can make our lives considerably easier. So this is our infection control audit. This is an automated audit that gives you scores at the end of it and also an action plan. And we keep our infection control audit up to date. So during COVID, we put in all kinds of extra stuff into the audit. And then after COVID dissipated, then we removed it. So I think it is important that however you decide to do your infection control audit, you make sure it does reflect the times that we're practicing in. Compliance management software, again, this is our system at Dentistry Compliance, but our competitors have systems just like this as well. And this will schedule and manage all your compliance tasks. So obviously we've been talking about infection control, so all your infection control tasks will be found within the system. And our emphasis is always on making this as simple and intuitive as possible. It still, though, leaves questions in lots of practices' minds. You know, how do we know if we've got it right? How do we know if we've interpreted everything correctly? How do we know if our interpretation is the same as the CQC's? And, you know, I think that can be a real source of stress to a lot of practices. And a lot of practices feel they're staring down this long, confusing tunnel of confusing requirements. And really, I just really want to finish up with saying that you're not alone. There is plenty of help out there that you can get. We can help you at Dentistry Compliance. Of course we can. And that's how you get in touch with us if you'd like to. And even if you just want to ask us questions, things that you're not sure about, we will always help you, whether you are a client of ours and we support you or not. At the end of the day, I'm a dentist myself. We're all in this to protect the patients and protect our teams and then the wider community and our families. So if there's anything at any time that you're not sure of, then please do just ask. And I'd like to open now up to any questions. I'm going to look in the chat and hopefully see if we've got some questions. If we haven't got any questions in there, then please now add them. And I will be very happy to answer whatever you would like to ask. So I'll give you a few minutes and then please just pop your questions into the chat and I will happily answer them. It's pretty rare we don't get any questions at all. So, and the other thing I would say is there's no such thing as a daft question. So if you have got a question and you're thinking, oh, I don't know if this is a daft question, you might have, there will be other people out there that also have the same question. Oh, that is hello when doing airflow. Oh, sorry, I missed out a few here. How long does fit testing certificate last for? Oh, a great question. Fit testing certificate will last for the life of the mask. Yeah, so sorry, sorry. How long does the fit testing certificate last for? So that will last, sorry, that's the fit checking I was referring to there. Fit testing certificate will last a year. How often should masks be changed between patients? So they are disposable single-use items. And then we've got, sorry, can we see, sorry, hello, when doing airflow cleans can, I think we just need a little bit more information on that question. I don't think it's quite all there. The question says, hello, when doing airflow cleans, can asthmatic patients, if you wouldn't mind just popping in a bit more into that question, not quite sure exactly what you're asking. Sorry, can we see asthmatic patients? Yes, you can. I think I've understood your question correctly, but do please feel to clarify it if I haven't. I don't see any more questions there at the moment. Anything else anybody wants to ask, but not just related to this? Oh, hello, when doing airflow cleans, can we see asthmatic patients? I thank you very much for clarifying that. I think local risk assessment, really, I think, you know, sort of think about whether doing an airflow clean is right at the moment and whether you should perhaps not be using it right now when you're seeing an asthmatic patient. So local risk assessment, and also depends how asthmatic they are, whether they are on medication, whether they've used their medication, whether they got their medication with them. So I think local clinical judgment and local risk assessment important there. Oh, great questions. Haven't seen some of these questions before. Doesn't need to just be related to this presentation. Any infection control questions, please feel free to ask them. Should instruments left at the end of the day be stored dry until the day after? Again, a really good question, very well thought out question. So instruments that are left to dry at the end of the day can be put into a cupboard to dry, and then they can be used if they're going to be used then the next day. You should dry instruments that have come out of the autoclave though with a non-linting cloth and then package them. Thank you for asking that. Anything else anybody wants to ask? A little bit of time. And instruments be cycled in the drawer, unpouched and then pouched over the weekend? No. So you shouldn't keep any uncovered instruments in a drawer at all. So instruments can be stored on a tray if they're going to be used during that day. The tray should be kept in a cupboard, but you shouldn't be keeping any instruments in a cycle, in a drawer, unpouched. Okay, so clarified here, I mean if they are dirty instruments. Sorry, right, okay, this is a really good question. So I think that the initial question was, should instruments be left at the end of the day be stored dry until the day after? So this is contaminated instruments. They should not be stored dry, no. They can be stored moist. If you store them dry, then anything on the instruments is going to stick to the instruments, making it really difficult to clean them. If it isn't unacceptable to leave dirty instruments overnight, not any longer than overnight. What you would need to do, though, is make sure that it's very, very clear that these are dirty instruments that have not been sterilized. So there must be no possibility that anyone will make a mistake and think that the instruments have been sterilized when they haven't. So if you get to the end of the day and you don't have time to run the autoclave, then that isn't the end of the world. You can store the instruments overnight, but make sure that they are labeled as dirty instruments and store them moist, so you can get clean. You can get foam that you spray onto them that keeps them moist overnight. Does that answer your question? Right, so then, thank you. So now we've got a question here that says, sterilized mirrors on a clean tray that will be used that day and used frequently, so cycled as used and sterilized. Yeah, that is fine. They can't be stored in a drawer, though. They need to be stored on a sterilized tray or a disposable tray insert, and they need to be in a cupboard. They don't need to be pouched, though. Does that make sense? Don't hesitate to say if it doesn't. Good. Anything else? Can we access slides of today? Most definitely, yes. So after this presentation, I will be sending the slides to Rose. Rose will send them out to you. So I'll send them in a slide format so that you can run this presentation with your team in the practice. And actually, running it with your team in the practice, you can even make it into a slightly fun event where you ask the question, is this true or false? And then you ask for the participants in the session to say whether it's true or false. I've done that live in to big audiences before, and it is quite good. Couldn't do it today, but because it just just can't. But it is quite a good thing to do. So we'll send you the presentation and also a PDF as well. So how do we reduce waste if we have to pouch instruments for patients? What is your recommended method for storage in the surgery? Okay, so ideally you shouldn't be storing in the surgery, but a lot of practices don't have enough room for to store them elsewhere. If you are going to store them in the surgery, then they should be pouched. Frequently used items can be used during that day so that you don't have to pouch everything. You can store it on trays, must be in the cupboards though. Does that answer your question? No, it possibly doesn't answer how do we reduce waste. It's a really important question, this waste reduction. This is obviously paper waste, which pouching is paper waste, which can be recycled. Of much more concern is single-use plastics. So thinking about how you can reduce single-use plastics in the surgery is important. So things like your mouth rinsing cup, don't use plastic ones, they can't be recycled. So think about using autoclavable mouthwash beakers. That's a very good thing to be thinking about. Things like saliva ejectors and 3-in-1 air syringe tips, autoclave tips. Could you perhaps be looking at autoclavable items there? And I think that yes, I think the answer to that is yes. We need new guidance though, and the guidance is not yet forthcoming, but there are some things that you can do that can make a difference now. Pouches have plastics, yes, they do, but they can still be recycled. Plastics obviously can be recycled. So our manager said they must go in clinical. No, they don't need to go in clinical. They can go in, in fact, they can be recycled. We use the plastic part of a pouch as part of the tray liner, and the non-contaminated paper part goes into recycling, if that helps. Yep, that's a good solution. It's very difficult though. And if you'd like a session on HTM 0701, so that is, it's now called the Safe and Sustainable Management of Healthcare Waste, then please would you put that onto your feedback forms that Rose will be sending out, because essentially the guidance in HTM 0701 conflicts with the guidance in HTM 0105. So if you'd like me to do a session on that, I'd be very happy to do. Did you say plastic cups don't have to go into clinical waste? No, they don't. So HTM 0701, which is this safe and sustainable disposable management of healthcare waste, is exceptionally confusing. So what that says now is that you only need to put things into clinical waste. That's orange bags that have come from the treatment of a patient with a known infection. Now, this goes against everything we've done for years and years and years, because we've had to assume that all patients were infectious. The new guidance says that you only put items into clinical waste, orange bags, if the patient has got a known infection. The issue with that, of course, elephant in the room, is how do you know if a patient has got a known infection or not? Any more questions? As I say, if you would like a session on management of waste, I'd be very happy to do that for you. We're doing patient records and consent at the April session, but if you'd like healthcare waste, very happy to do that for the May session. Any more questions? Right. Okay, good. No, okay, all right. I think if there's nothing else, then I will, thank you, Rose. Rose has shared the link for the next one on the 29th of April. So we are avoiding we're avoiding March because of everybody wanting to complete their UDA. So the next session will be on the 29th of April. Thank you for all your thank yous. It's an absolute pleasure. And as I said, anytime you need any help of any